Nag is trained both in India and UK. He had more than 12-13 years of UK experience and has now set up his own hospital in Hooghly, West Bengal called Deeptakshi Eye Hospital. And he's a prolific surgeon. And let's see what Dr. Nag presents on Rexis complications in intumescent mature cataract.
Thank you, Sugato. Thank you. And thank you again for inviting me and also to Scientific Committee AIOC. Today, I'm going to talk about Rexis complications in intumescent mature cataract and how to prevent it. We have, over the years, doing our cataract surgery, especially in this intumescent mature cataract, we have come across lots of cataracts where we lost the Rexis and ended up having so many problems. So today I'm just going about talking about this particular situation where intumescent white mature cataract can cause problem. So what are the complications? These are the runway Rexis and Argentinian flag sign, which we have in our experience come across quite a few times. And what are the causes of these complications in these situations? There is high intralenticulaar pressure, there's convex anterior lens capsule, shallow anterior chamber, trapped liquefied lens material behind the equator, pushing the nucleus upwards as soon as the anterior capsule is punctured. And also diabetes and young patients are very prone to have it. And to avoid these Argentine flag signs, what we need to do? First, foremost, we need to check the speculum so that there is no undue pressure on the globe. Always stay in the capsule first. Fill AC antechamber with OVD. Take a fresh 23 or 24 gauge needle on a smooth 2 cc glass syringe. And why I do that, I'll come across and tell you later on. And engage the capsule with beveled edge pointing downwards. And there is also its important point. And the most important is you have to start suctioning just before puncturing the anterior capsule at a point before reaching the center, and you have to keep sucking and tap the nucleus or nudge the nucleus down a few times as long as soft lens matter is coming to the needle or the syringe, and then you refill the AC with OVD. There are optional extras which we all have tried. I have tried too. I've tried so many options, but nowadays with this new technique, I really don't have to use these. These are the pre-op IV mannitol, minimum volume of local anesthetics if subtenon on perivalvular block is given. I usually do it on a topical now. High viscous OVDs, small Rexis followed by enlargement after cortical suction, and spiral Rexis. Both of them takes longer time. And in this particular scenario, I prefer to use this Haldipurkar microcapsular Rexis forceps, which suits very well with my hand, although I don't have any particular financial interest on this. And now I'm going to show you a few of the videos. Here is a mature cataract, and I'm just entering and see the bevel edge down, and here I punctured and I kept sucking as long as the lens matter keeps coming. And now once I'm happy, satisfied that no more fluid is coming, I just go with this micro Rexis forceps and then do the Rexis. Although in all normal situations, I do the Rexis with the cystitome, but here I prefer to do it the micro Rexis forceps because it gives more controlled hold. So here I don't have to worry, it's not running, there is no tendency of it running towards the periphery. I can wait, I can come back, I can put more OVDs and then go back, and slowly I can get the Rexis as big as I need. Or I do it on the topical, that's why the patient keeps moving, and here I put some more OVDs and then I go and do the Rexis as the size as much bigger as I want. Now it's done. Here is another one. Here also I have stained the capsule, and now I'm going to show you, this is the 23 gauge needle with a glass syringe which is very smooth, it's not getting stuck, and actually the same syringe which I use for using the trypan blue, I use the same syringe to do the suction. So I started suctioning before puncturing, and now I keep sucking. Although in this particular situation, there was not much cortical matter there, but still I didn't take any chance. So I still punctured and sucked as much as I could. Now with the same rhexis forceps, I went in and did the rhexis. Now, before I tried all sort of techniques like optional lectures and as well as phaco punch, but never worked consistently. So I had to sort out and have to keep changing until I found this particular technique. For last 5 years, while I'm using this technique, I just lost only one case where the rhexis ran out, and that too was because I was not vigilant enough. I didn't take out most of the loose matter before I actually started doing the phaco. I started doing the rhexis. Here you can see this a very intumescent cataract. I did the side port. So nowadays I make sure that even I nudge sometimes the peripheral cortical region so that most of the loose matter comes out and doesn't keep any locally intact. And I have not come across any Argentine flag sign in last 5 years. Today, in fact, today I did 3 of the cases this morning and all came out very nicely. And especially in this pandemic situation, more and more people are coming with this hard white mature cataract. Usually we used to get 2 in a list, but now I'm getting 4 or 5 even in a list, because those are the people are actually desperate to have the surgery, and we are getting more and more of these people recently with very intumescent white mature cataract. So I have stained the capsule now and put some, and I use normal hypermalose, that's normal methyl cellulose. I don't use Hilon or any other high viscous material now. Just a simple step. Now I'm going to puncture it and then keep sucking. You can see the cortical matter just slowly is coming towards the needle, and I am nudging the nucleus down. You are very safe as long as you right in the middle, the tip, you can see the tip, then it's very safe. You can nudge down the nucleus as many times as you want to release all the entrapped cortical matter behind the equator, so that there is no push of the nucleus or there is no chances of rhexis running out. See, I can easily wait and put some more viscoelastic and then go and do the rhexis. This is very simple step. It doesn't take longer time like double rhexis, like spiral rhexis. You can do it straight away. You don't have to use high viscous OVDs, no extra cost involved, and it's very simple. You can just do it nice and round rhexis. Here is the last case. Here I'm just going to puncture just before. See, the fluid came out, and then now I'm nudging the nucleus, and more and more that the nucleus is the cortical matter is coming, more and more coming. Sorry, the patient is on topical, it keeps moving, and also because of the constant of time, I had to increase the speed a little bit. That's why the movement is so much. Now I'm going to put some more OVDs, and now I'm milking out from with the experience of that locally remaining in the periphery. Nowadays, if there is any chance of that, I can see I just sort of gently milk it out, any of those fluid or entrapped cortical matter from the periphery, and then I go ahead with the rhexis forceps to do the rhexis. So less stressful and less stress to the zonule as well as the capsule. It is actually tearing very nicely, and as I'm going through, there is no tendency of going it to the periphery. So here is a nice and complete rexis. And if I can do it, I'm sure you can do it too. You can even do it much better. And it's very simple, much economical, takes less time, and you won't have much problem anymore like I haven't got in last 5 years. Thank you very much. Thank you. And I'll hand over it to Sugato.
Please unshare your screen, Dr. Nag.
I'm doing
Thank you
that.
for the lovely presentation.